Jonathan Hobbs here, developer of the Hobbs Masters Needling series and chairman of the AACP in the UK. Just want to take a few moments to talk to you about needling for headaches. There are lots of different types of headaches, and we can look at the different diagnostic criteria for these, and in some cases you may have more than one headache presentation in place at the same time. It's not a diagnosis of exclusion. Having one doesn't necessarily mean that you wouldn't have another. And there are different reasons for getting these, primary, secondary, and so on. And when it comes to acupuncture and dry needling, I find a question I get asked a lot, particularly when I'm teaching about headaches and migraines or craniofacial needling, is that people will ask me, well, what's my prescription for this? What's my prescription for that? And sometimes it's not as simple as that. And I find that clinicians can get very wound up with and bound down with the idea of a certain prescription without thinking about the pathophysiology versus the mechanism. And so I've noticed there are three things that most clinicians could probably do to improve their treatments of headaches and migraines. And this is across the board, whether you're a traditional acupuncturist or a trigger point practitioner or anything in between. Three things that I'd ask you to consider. Now, it doesn't mean you've always got to do these three things, but you want to think about these three things when you're needling. The first thing is needling deep into the neck. And I'm talking about needling structures like semispinalis capitis or obliquus capitis inferior and so on. Now, these structures can be quite deep inside the neck, depending on the build of the neck. And so one of the things I would say about that is don't needle these unless you've had specific instruction on the anatomy and the location of these points and what you're trying to achieve with that. But it's something to consider, needling deep into the neck. The second thing to consider is the pain referral from other structures. Is this referring from sternocleidomastoid, to the eye, to the ear, to the side of the head, temporalis? Is it referring there? Is it referring from upper trapezius to the side of the head, occipitalis, frontalis? Is there some relationship with the aponeurosis neurotica and so on? Is there some myofascial component referring in that isn't as obvious as being in the neck? I would consider that. And the third thing I would consider is distal needling. And this is something that a lot of people miss because they focus on the neck and think about the central effects that you can obtain by needling distally and influencing that central descending analgesic mechanism. So three things to always consider. You don't have to do them all, but certainly consider them when you're needling. And I think for a lot of people, if you did, you could enhance and improve those outcomes with your treatment of headaches and migraines. So deep needling in the neck, needling surrounding myofascial points, and needling peripherally. I teach all of these on a number of courses that I deliver, particularly the headaches, migraines and TMD course. Love to see you on one of those sometime soon. But you go away, practice, use those techniques, explore those ideas, entertain those ideas, and see how you can enhance your outcomes for headaches and migraines. And I'll see you soon. You take care. Bye-bye.